So how has my diagnosis of vitiligo evolved within the past couple years, specifically in my skin and color patients? First and foremost, I use my Woods lamp every single time I have a patient that comes in with any type of concern where it's white spots or discoloration. Years prior, I may have thought, oh, I can make this diagnosis of vitiligo without the Woods lamp. No, a Woods lamp is essential to evaluating your patients for vitiligo. So that is a key that when I'm talking to colleagues and making the diagnosis is make sure you're using your Woods lamp. It is your tool to have. The most common misconceptions I have about vitiligo, not necessarily me, but maybe patients or other colleagues is, one, there's no treatment. Two, I've had it for years and years and years, and because I've had it so long, I'm not going to re-pigment. So when I have patients coming into the office now, I'm excited because we have FDA-approved medications for them, in addition to the gold standard of using narrowband UVB, and we're gonna have new medications hitting the market. So that's a misconception that there's no treatments. Yes, we have treatments. The other misconception is, okay, I've had my vitiligo for 20 years, I'm probably not gonna re-pigment. No, that is not the case. No matter how short or how long you've had your vitiligo, I always instill hope into my patients that there is that potential that we can re-pigment your skin. So when am I going to choose a systemic therapy for a patient with vitiligo versus just topicals or phototherapy? If your patient has active disease, it is essential that you are using something systemically. So what are the signs you're going to look for active disease? If your patient has an increase in body surface area, a 1% increase in body surface area within 4 weeks, it's active. If your patient has a confetti style depigmentation, that's active. If you see a Kebner phenomenon, that's active. If you see the trichome, that's active. If you see an inflammatory border around their vitiligo, that's active. That is where they need systemics. They need to be or have aggressive therapy to get that vitiligo under control. Have I tailored my treatment for my patients depending upon where the vitiligo is or the patient itself? Yes and no. We know that there are areas on the body that are harder to pigment. For example, the hands, the feet, the ankles may be harder to pigment because there are no hair follicles there. So I may tailor adding a topical along with phototherapy just to be aggressive. The reality is, though, with majority of my vitiligo patients, I try to be as aggressive as I can because there's 3 goals we want to do with treatment, right? We want to stop that autoimmune attack against the melanocytes. We want to re-pigment the skin, and we want to maintain that pigmentation. So that's usually where the aggressive approach is going to come into play, where I am going to use topicals, narrowband, and then like for the active disease patients, those systemics as well. So how has the approval of ruxolitinib changed how we treat vitiligo? Tremendously. Every patient that comes into my office that has a diagnosis of non-segmental vitiligo is given a prescription for ruxolitinib. Why? Because we have evidence that this medication works. What I'm doing as well, there are studies out there that indicate a higher rate or faster rate of pigmentation when you're using ruxolitinib in addition to narrowband light. So again, it's my aggressive approach to re-pigment these patients, and I do it by using ruxolitinib in addition to narrowband treatments.